A very good evening to one and all. I, Ravisha Rana, on behalf of Mankind Pharma, welcome all the delegates who are present today with us in our Innovation and Advances in Orthopedic Surgery program. Also, I would like to take the opportunity to welcome our very esteemed speaker of the evening, Dr. Vikram Shah sir and Dr. Kalpesh Shah sir. Also, we have today with us medical advisor of Mankind Pharma, Dr. Prashant Agarwal, who is going to moderate the session. Before commencing towards the very enlightening session, I would like to take the opportunity to take you through the journey of Mankind Pharma in pharma industry so far. Mankind was established in 1995, founded by Mr. R.C. Juneja sir. Mankind is ranked number 1 prescription-wise and ranked 4th value-wise. Mankind has strong presence across prescription drugs, OTC, and veterinary medicine as well. Mankind has strong presence over all major therapy areas and has got leadership in many. Here in Mankind, our philosophy is serving life and stands on its 3 pillars of quality, affordability, and availability. As a responsible pharmaceutical company, Mankind Pharma is helping its employees, doctors, and patients, as well as consumers in numerous ways, committed to its philosophy of serving life. We also feel proud to announce Mankind has got its first patent for anti-diabetic research molecule GPR 119. With this, I would like to thank each one of you who has joined today with us in this enlightening session. And with this, I would like to hand over the session to Dr. Prashant.
Thank you, Ravisha. And thank you everyone who has joined us here with this one of its kind session for especially for the orthopedic surgeon. And total knee replacement is one of its kind of surgery which has been very dreadful throughout the year. But it has been made really easy by Dr. Vikram Shah, who is the innovator of one of the unique technique in this era. So without taking much time, I invite Dr. Vikram Shah, who is founder, chairman, and managing director of Shelby Hospitals, which is a chain of orthopedic hospitals across India and which is headquartered at Ahmedabad. Dr. Shah, after completing his medical degree in MS Orthopedics, worked and trained at various hospitals and like Ormskirk and Wingtington Hospital in UK and then in USA also. And once he returned to India, he established Shelby Hospital and Research Center in 1994. Dr. Shah revolutionized the once dreaded total knee replacement surgery with own surgical process innovation of zero technique that minimizes surgery time from hours to 8 to 10 minutes. He invented the OS needle, which passes through the bone and now used by orthopedic doctors across the world. He has won many awards in his career, like coveted Medical Tourism Award consecutively for 2 years in 2016 and 17, BC Roy Oration Award in 2023, and awarded by Johnson & Johnson for invention of the OS needle. Dr. Shah received in 2014 the Gujarat Innovation Society's Hercules Award for the innovation of zero technique for the joint replacement surgery. He has been envisioning the future in advance and preparing the organization to be a front runner in multi-specialty healthcare delivery. With this, I request Dr. Vikram Shah to have his opening remarks. Then I will ask him to share start the proceedings for this evening. Dr. Vikram Shah, sir.
Good evening, everyone. Now, all over India, more than 1,000 plus orthopedic surgeons perform knee and hip replacement surgeries, which was not the case before 30 years when I came back from UK and USA before 27 years in 1994. Across country, there were not more than dozens of surgeons who were doing it on regular basis. So in last 27 years, this surgery has gone from hands of senior surgeons to young budding surgeons. from metros to towns, and thousands and thousands of people across country have been benefited by this wonderful surgery. Not only that, as medical tourism has grown over the years in India, thousands of patients coming from Africa, Middle East, and Southeast Asia have been benefited from this surgery. This knee or hip replacement surgery is supposed to be most value of money as far as American investigations have done, that it gives the best value for money spent by government or by insurance company. Now, talking about joint replacement surgery, I remember discreetly that when we started doing it after coming back, things were much more different. We were not getting instruments. Instrument sets were also half. We did not have full inventory of implants also, which is not the case nowadays. Having said this, our experience also was not enough for Indian patients, which are definitely different than Africans or European, American, Caucasians. Our bones are much softer, our soft tissues are not as good as them. So we also passed through a learning process and we learned a lot in initial 3 to 5 years time. And with that, learning kept on increasing as we did more and more cases. We saw more and more complications. And today, as we stand, as Dr. Agrawal said, that we do in 10-15 minutes primary simple total knee replacement, which we used to take 2 hours at a given point of time. So I'm now handing over to Dr. Kalpesh Shah, who is a senior consultant in Shelby's team. He himself has done thousands of joints by now. He will take you through the surgery, which is pre-recorded, and then we will have a question answer. Thank you.
Thank you, sir. So now I invite Dr. Kalpesh Shah, who is a senior joint replacement surgeon at Shelby Hospital with more than 15 years of experience and has done more than 13,000 surgeries in his career. So, Dr. Kalpesh Shah, over to you.
Yeah. So let me start by sharing my screen. Right, Prashant, is it visible?
Yes, it is visible.
Okay, so we'll be showing a surgery of total knee replacement of the right knee in case of varus deformity, medial compartment osteoarthritis. Let me give you some background of the patient. This patient is around 64-year-old female with no major medical illness. We'll be operating on the right knee. She has got correctable varus deformity with no FFD. These are her x-rays. Her x-rays, as we can see on the right side, these are the valgus and varus stress views. Here we can see there is no tightness of the medial collateral ligament. It is a correctable deformity. While on this X-ray, in the varus stress view, we can see that the lateral collateral ligament is a bit stretched. So this helps us in planning our surgery, how much release we want to do, how much bone we are going to cut, and this lateral view can tell us how much slope we are going to keep in tibia. So this entire thing helps us in our planning. So we plan the entire surgery before we proceed with the incision. Once the surgery, we know what we need to do, we go ahead with this surgery. This is the leg of the patient. This is alignment. Alignment is almost normal, no recurvatum. Flexion, she has got almost full range of movement. And there is slight varus. This is the stability. Lateral ligament is slightly stretched, while medially it is easily opening, correctable varus deformity. Stretched lateral ligament, correctable varus deformity. Now we use this special device, which is a leg holder we tie to the leg. And then we have a device with slots which go under the leg where we can, put this stand. And because of this, we are able to, avoid the need of extra assistant. We do the surgery with surgeon, one assistant and a staff. So it makes it very easy. Now, this is the incision. We take midline incision, palpate the tibial tuberosity and go straight anteriorly midline. We cut the skin and subcutaneous tissue. We take care here, we don't make a lot of flaps. Minimum soft tissue dissection is the key to success of this surgery. So after that, once the soft tissue dissection is done, we go ahead with the arthrotomy. Here, if one chooses, one can mark the arthrotomy so that closure is easier and meticulous. This is the arthrotomy being performed. We generally take anteromedial arthrotomy. So in this anteromedial approach, we cut through the medial part of the patellar tendon and quadriceps tendon. Once this is done, we elevate the medial superficial and deep medial collateral ligament. This medial release is done for exposure. In this particular case, as we have seen, this is a correctable deformity. We will not be going ahead with too much of release. We'll have minimum release here. So this release, medial release, is just for exposure. As we have seen on the X-rays, there were osteophytes on the tibia on the medial side. So we will be taking down those osteophytes. So with the help of a nibbler, we remove those osteophytes. Once this is done, we complete our medial release past the midline. It is very important to cross the midline. A lot of people, a lot of surgeons make mistake here, because if you do not cross the midline and you try to dislocate the tibia in subsequent steps, you might just tear or rupture the ligament. Now, this is correctable deformity. So medial joint line is opening very well. So now we go ahead with our further exposure. The medial infrapatellar fat pad, part of it we will remove so that our exposure is better. We removed some part of fat pad, and then we cut anterior cruciate ligament and posterior cruciate ligament. These two ligaments have no function because they are substituted in the design of the implant itself. In all our cases, we use posterior stabilized knee, so we don't need to retain the posterior cruciate ligament. Now we dislocate the tibia anteriorly. At this stage, we have to take care that we don't injure the vessel posteriorly. There is artery going around in the posterior part of the knee, so we have to take care. This retractor we have put to protect the medial collateral ligament from injury. Here now we remove the lateral meniscus. Now we take the tibial cut. Tibial cut is to be taken perpendicular to the tibial mechanical axis, that is center of the knee to the center of the ankle. Generally, in most of the cases, almost all the surgeons are using jig to take this cut, but because in our institute we are doing almost 20 to 25 surgeries per day, we have gotten used to this step, so we do it freehand. We don't use jig, but our advice to surgeons with less experience that they should use the jig. As this deformity was flexible, it was correctable deformity, and the knee was lax, we have cut less of tibia here. This is the proximal cut tibial surface. Here, as we can see, we have cut around 8 to 9 millimeter of tibia. Once that is done, we just make sure that our cut is perfect. Here, this rod should coincide with the center of the ankle, which is very well coinciding. So that means the cut is perpendicular to the mechanical axis of tibia. Now we will do our preparation of the tibia. This is the tibial tray. And while selecting the size of the tibial tray, we need to make sure that we get full coverage of the tibia and the tray is sitting on the rim of the tibia so that cortical bone gives good support and there is the chances of collapse of tibia is minimized. Also, we need to take care that bone at the Gerdy's tubercle is removed so that we don't select one size lower tibia. This is the tibial keel preparation. Again, if surgeon is not very much experienced, this step has to be performed last. But as I've mentioned, we do routinely 20-25 cases, so we just finish off this step at this stage. Now we are opening the femoral medullary canal for taking distal femoral cut. We will be using intramedullary distal femoral cutting jig. This is the intramedullary jig. This jig helps us control our cut, and in whichever angle we want, it will allow us to cut the distal femoral part. Here we have selected 9 mm of distal cut and 6 mm of valgus angle, 6 degrees of valgus angle. Now we are taking distal femoral cut. Now, once this step is done, we have to size the femur. So this is the femoral sizer. It will tell us which size of femur is suitable for this patient. Also, we will be adjusting our femoral gaps, flexion gap here, and deciding on our rotation, that what rotation is suitable for this patient. As we had seen on the x-rays, the lateral collateral ligament was stretched. So here the lateral flexion gap is slightly higher. So we need to externally rotate the femoral component. Now, when the jig has got provision to externally rotate, we can directly fix the jig with external rotation. If there is no provision for that, then we have to rotate the jig manually, as I'm showing you here, and then fix the jig in that rotation. Once this rotation is fixed, then we can select the size of the implant we are going to use, and then put pins according to that size. This is the femoral AP cutting jig. So this jig will help us to shape our femur according to the inner surface of the implant. Since there are 4 to 5 cuts to be made and there is a lot of wobbling, this jig needs to be fixed properly. So as we can see, we have got 2 pins, and then we'll be putting in 2 screws also to fix this jig. Now we are taking anterior femoral cut. While taking this cut, we need to be a bit vigilant, because if our sizing is not perfect, we might notch the anterior cortex of the femur, which can then increase the chances of periprosthetic fracture. So we need to be vigilant in this case. This is the anterior chamfer cut being made. After this, we'll take posterior cut and posterior chamfer cut. Now, while taking the posterior cut, we need to be very careful because this area we can damage medial collateral ligament or lateral collateral ligament, or here in the center there can be injury to the popliteal artery. So it's a very crucial step. We need to be very vigilant while performing this step. After that, we take posterior chamfer cut. So now the shape has been given to the femur. We will prepare a slot for the next jig with reciprocating saw. Now we'll be putting in the next jig. Here we'll be taking the box cut with the help of reciprocating saw. This is an important step. While removing this piece of bone, we need to make sure that we are not injuring the artery, because the knee is completely flexed and the content of popliteal fossa may be pushed into the surgical space. So we need to be very careful there. Now we are removing the osteophytes. This is the medial osteophyte which we are removing. It is important to remove this osteophyte because otherwise it will tent the medial collateral ligament and the knee will remain tight in flexion. The balancing doesn't come properly. These are the posterior osteophytes we are removing. Same thing on the lateral side. We will also at this stage remove the remnant of posterior part of the medial meniscus. We make sure that all the osteophytes have been removed so that we can get complete range of motion. Now is the surgery is almost done. Now we have to see the trial, check the trial and see whether everything is okay or not. This is the trial femoral component. So we have now fitted the trial component. It's sitting very well. This is the trial tibial component. It's going in smooth. Now we straighten the knee. So now we can check the alignment, stability. See, the knee is very stable. Medially and laterally, completely stable. Okay, these are the components. Stable. Now we'll move it through the range of motion, and we also see the alignment. Alignment appears to be proper. We take it through the full range of motion. It is proper, and we check the medial collateral ligament. Now the tension in the medial collateral ligament is one thing which a surgeon should be aware of, how much he wants to keep it tense. Too tight a medial collateral ligament generally creates problem in the knee. So good result can be achieved if surgeon knows how much tension he wants to keep in the medial collateral ligament. And there the experience of the surgeon comes into the play. So this knee is completely stable in flexion as well with good tracking of patella. So now we accept this trial and we move ahead with resurfacing of the patella. The knee has no FFP, no recurvatum. So now we are going ahead with resurfacing of patella in this case. Patella resurfacing, again, it depending on the surgeon's choice. There are a lot of surgeons who don't replace patella. In all our cases, as a matter of protocol, we replace our patellas. While replacing patella, it is very important to take care that we don't make it very thin. In this case, the remaining patellar bone stock is around 13 to 14 millimeter. Now we'll prepare lugs for the patella button. After preparation of patella, this is a crucial step. There is a tissue fat pad which is present on the undersurface of quadriceps tendon just above the patella. We usually remove this fat because otherwise it can get stuck in the notch of the femur and give rise to patella clunk later on. So we remove that fat pad and now take the knee through full range of motion to see the tracking. As we can see, patella is tracking very nicely throughout the range of motion. So now this trial is acceptable, and now we go ahead with final cementing of the implant. Look at the fit of the femur. It is very nicely, snugly fitting. Now we'll prepare the surface. This medial sclerotic tibial bone, we just drill few holes so that there is good hold of the cement there. After that, we plug the intramedullary open canal which was opened by us so that post-operative blood loss can be minimized. We just put a bone plug in there. Right, and now we wash the entire surface off so that we can have good cementing here. This is how the surface looks after preparation. Now we go ahead with implantation. These are the actual implants. Here in this particular case, we are using implants with coating of niobium nitrate. It's a kind of ceramic coating on the metal. This is the femoral component, actual femoral component. Now we'll be putting on cement. We fix this component with methyl methacrylate. So we are now applying it on the undersurface of the implants. In longevity of the total knee replacement, the cementing is a crucial factor. So cementing has to be done very meticulously. Now we apply cement on the femoral undersurface of femoral component. These are all the components. Now we'll cement it on the bones. This is on the femur. On the flat horizontal surfaces, we pressurize the cement with hand. So on the posterior and anterior cuts, we pressurize cement with hand and then hammer the component inside. This is the excess cement which we will remove. Now we'll go ahead with cementing of the tibial component. The tibial surface has been prepared very meticulously. Now we put this tibial component on and hammer that thing in. We'll remove all the excess cement from here. Now we'll cement the patellar button. Once this is done, we will put the insert inside. Insert is the plastic material, which is polyethylene, in between femur and tibia. This is the insert. It is made of ultra high molecular weight polyethylene. We'll lock it into the tibial component. And we'll straighten the knee now. So now components have been cemented. We'll pressurize the patellar button and remove the excess cement now. So now it's fully stable knee, good alignment. We take it to range of motion again to see if tracking is okay. See, beautiful patellar tracking we can see. So this knee is completely replaced with good alignment, good stability. We'll see the post-operative X-ray of this knee. So this is the post-operative X-ray of the knee. This is the AP X-ray. This is the lateral X-ray. We can see good alignment, overall alignment around 6 to 7 degrees of valgus is there. And this is the tibial component. Femoral component is in 6 degrees of valgus. On the lateral X-ray, we can see there is no notching. Component fit is very nice. We have preserved the posterior offset and maintained the tibial slope. Patellar thickness is also good. So that was about the surgery. Now I'll hand it over to Dr. Yeah, I will take a moment here to discuss our post-operative protocol as well. Post-operatively, now this patient, because these surgeries we finish off in almost around 10 minutes or so, and there is minimum soft tissue dissection. The patients have minimum pain, and we make these patients stand immediately 2 hours after the surgery, and we keep these patients on minimum pain medicines, and the requirement for blood is also reduced. In around a day or so, patient can be discharged, and in 5 days time, patient is walking without support and moving out of house, and they can start going to work in 1 week. So recovery is very fast. It is purely because of better soft tissue handling, better balancing, and overall surgical technique. So that is what we have actually achieved in over the period of years, because earlier after knee replacement surgeries, patients used to be in bed for 24 hours, and then there were increased chances of deep vein thrombosis. Now, because we make the patient stand in 2 hours, the chances of the incidences of deep vein thrombosis have also reduced. And generally the most common deterrent for the patient to undergo knee replacement is post-operative pain. They are so much afraid of post-operative pain, but with the innovation of this technique and our surgical skills, we have been able to reduce post-operative pain to almost zero. So I think that is a very huge step forward. Now I'll hand over the session to Dr. Vikram Shah for question answers.
Thank you, Dr. Kalpesh. Welcome back, sir. So, sir, we will start with your comments first. So, about this surgery. So any tips which you also would like to share?
Well, I would straightway go for question and answer because Dr. Kalpesh has explained this whole
Yes,
procedure
sir.
in depth and in a lucid way, and we have been able to show the every step in a proper way. So, we go for a question and answer straight away.
Sure. Thank you, sir. So, sir, first question which I can see is which patellar component is preferred, all poly or metal back, and why?
Well, I don't think many company now make metal back patella at all. I don't think one or two companies are making. It is not working. There is a lot of plastic wear because of metal back. So almost all patella are all poly.
Okay. Thank you, sir. Okay, so what is the average life of a knee implant?
Where average life of a knee replaced knee joint is actually how the surgery is performed. The surgery is done by us well, way back 24, 25 years. They are all still moving around. And they were the joints which were made before 25 years. So that is the older technology joints. It all also depend on how patient is using it. Some patients are doing something which they should not be doing, or overusing it, or abusing it. So the life may reduce, but patients who are having a lower level of mobility as well as wisdom of using it nicely, it can go on for 25 years. There is no issue.
Okay, so sir, I guess questions are coming very frequently. So the next is which is better, measured resection or gap balancing?
See, both are same if you ask me. Both are same. As far as measured resection is concerned, you measure tibia 9 mm, 10 mm, and then cut it, or you cut arbitrarily 9, 10 mm and fill the gap. In my opinion, both the things are same. Whether you see from this side or the other side, it doesn't matter really. You do what you are comfortable with. Only thing is that don't cut too much, because a number of times joints do open up, and you go for a measured cut and you cut 9, 10 mm, particularly in cases where previous high tibial osteotomy is done, and you again cut 10 mm, the joint really opens up later on, and you end up putting 15, 18 mm plastic.
Okay. Thank you, sir. So before I go for the next technical question, if you allow, sir, may I ask one general question, sir, for our budding orthopedicians?
Sure.
Okay. So like, sir, you have been an entrepreneur. I mean, you are one entrepreneur, I mean, who has changed this orthopedic surgery and all. So what advice will you give to budding orthopedicians? I mean, how to move ahead, how to think big in terms of, I mean, orthopedic surgeries and also.
Well, to be very honest with you, and with all the friends who are seeing this program, what is more important in life is what do you want from your life? What will satisfy you? What will make you happy? Because one mistake many surgeons do is they run after money. And once you run after money, once you are moneyed, your interest of practice goes down. And then you don't do good work. Either you are in a stock exchange, or you are sitting in the clubs having lot of friends, or you are doing something else. You enter in politics because you are getting bored with what you are doing. So, to all my friends, what I want to tell is love what you are doing. If you love what you are doing, then you will go anywhere in the world.
Very apt, sir. Thank you. Okay, sir, to move forward with the next question, sir. So this is question related to robotics in total knee replacement. So Dr. Hardik wants to understand what is the role of navigation and robotics in total knee replacement.
I am a firm believer of robotics as well as artificial intelligence. and it will be able to help us in a coming time. To be very honest and fair, in last 20 years, 5 generations of navigation and computers have come, and none of them are addressing total knee replacement in full. Even today, the companies are selling it as a marketing tool. Company executives coming to office and saying that X surgeon bought it and his practice has increased. That means it is not useful as on today. So it has not reached to the level, but it will reach. It will reach. Computers of past were never that useful, and now you have everything in phone. So we will get one of those things where it is really useful. Today's robotics or navigation only helps in cutting bone, which is very easy actually. Actually, what a surgeon needs help is at a soft tissue balancing, which it doesn't address. And when your problem is not addressed, how it is going to be helpful to you? So a day will come that it will somebody will address this part, and between 3 to 5 years something might come up where it is really helpful, because today's robotics today's robotics is not useful to senior surgeons who are really knowing the procedure, and not to the junior surgeons who are learning the procedure. So it is useless for both the party.
Thank you, sir. Sir, next two questions are there, sir. First is the use of tourniquet. Is it advised or not, sir?
We don't use tourniquet. We hardly ever use tourniquet. We avoid tourniquet because thigh pain is more common after TKR than pain around knee, and it hurts the tissue. So we use it, but it's at 10% of cases.
Thank you. Sir, this is the final question, sir. So, sir, he wants to understand your reviews about newer implant material such as zirconium and titanium nitride, sir.
See, basically, titanium niobium is a coating. Same way, zirconium is a coating on cobalt, chrome, molybdenum alloy. Same way, there is third coating which is now coming up, which is tungsten carbide coating, which is not yet marketed. Having said this, this is basically to reduce wear, because the life of implant is decided by the wear rate. So this is supposed to reduce the wear rate, and it is having superior gliding ability. Having said this, everything which is true in laboratory is not true in patient. So we have to see and wait for 5-10 years to come that how really it is working well or not.
Thank you, sir. Sir, one more question just came up. Can we take it?
Yeah, please go ahead.
Okay. How do you close the arthrotomy? Double bracing or single?
How it makes difference? We close it in flexion. You don't need to double it, because see, more tighter you make it, more avascular tissues you bring in. Muscle is a live tissue. Blood has to penetrate it. If you do it too much suturing, you are actually killing the muscle.
Thank you, sir. So, sir, that was the last question. So, thank you, sir. Thank you for this wonderful experience with that recorded session for the total knee replacement surgery and by Dr. Kalpesh, and all the advices and suggestions given by you, sir. So, thank you so much. Now, I invite Ms. Ravisha Rena once again for the thank you note.
Thanks, Dr. Prashant. As we have come to an end of the session, I would like to thank both of our eminent speakers, Dr. Vikram sir and Dr. Kalpesh sir, not only for providing us with a very enlightening session, but also for sparing their valuable time. And finally, I would like to conclude by saying thank you to each and every one of you who has joined today us in this session and has made this session a success. Thank you, everybody. Stay at home and stay safe. Thanks a lot.
Thank you, sir. Thank you, Dr. Kapesh. Thank you.